Sometimes we suddenly encounter in our busy practice cases of emergencies, and we'll be thinking about where to go, where to refer this case, what to do. So it's a tricky situation sometimes. So to talk on this, we have Dr. V.K. Gopi sir, and over to you, sir.
Thank you, Chairman. Good evening, everybody. Chairman, senior consultants, dear friends. I am immensely thankful to the organizers for giving me this opportunity. I consider this as a great honor to be in front of you on this stage. Pediatric emergencies is a vast topic. I am sure I will not be giving justice to the topic within a short span of time. And neonatal emergencies is the most challenging for any pediatrician or any pediatric surgeon, and the major push for the patient to be followed. A long list of pediatric neonatal surgical emergencies like congenital diaphragmatic hernia, esophageal atresia, coronal atresia, Pierre-Robin syndrome, congenital lobar emphysema, sequestration lung, congenital pulmonary adenomatous malformation, mass lesions, and the acute pneumothorax. In the first slide, we are seeing the X-ray of congenital diaphragmatic hernia. Very simple to diagnose. You can see the nasogastric tube going into the chest cavity. And in difficult cases, the simple test by doing barium enema, you can make the diagnosis. You can appreciate barium-filled colon going into the chest cavity. And the lower down, you are seeing CT scan done for the diagnosis of congenital diaphragmatic hernia, and it is shown to advise that it should not be done. And there is no role for CT scan in the diagnosis of diaphragmatic hernia in a child. And the last slide, you are seeing silo closure of the abdomen. Congenital diaphragmatic hernia prognosis is dictated by persistent pulmonary hypertension and pulmonary hypoplasia. But added points are high susceptibility to barotrauma and inadequate abdominal domain. And this baby, when the abdomen was closed after surgery, went into ventricular tachycardia and unable to resuscitate, we reopened the abdomen and silo was applied and baby could be saved. And this was done for the first time in our country, and the baby is now 4-year-old preschool. X-ray showing esophageal atresia. You can appreciate the orogastric tube getting blocked in the upper esophagus. That is confirmatory for esophageal atresia. And next slide is showing tracheoesophageal fistula. The fistula being ligated, and it is to be divided for establishing continuity of the esophagus. CT scan showing congenital lobar emphysema of the left upper lobe, almost filling the entire chest cavity, pushing the mediastinum away and compressing the contralateral lung. This baby had a resection of the left upper lobe and had uneventful recovery. Again, CT scan showing pulmonary adenomatous malformation. Previously, we used to call CCAM, affecting the left lower lobe. You can appreciate the mediastinal shift and compression of the contralateral lung. And acute condition, pneumothorax. On one slide, you are seeing unilateral pneumothorax, and the other slide, you are seeing bilateral pneumothorax. What is important is immediate diagnosis and immediate decompression of the thoracic cavity so as to enable the lung to expand. Neonatal abdominal emergencies are many, and intestinal atresia is the most common. Other conditions are Hirschsprung's disease, esophageal gastroschisis, anorectal malformations, malrotation, infantile hypertrophy pylori stenosis, meconium ileus, meconium plug, hypoplastic left colon, and necrotizing enterocolitis. And you can appreciate the jejunal atresia, the hugely dilated proximal bowel, and the distal bowel is very narrow, and the surgeon's duty is to make the anastomosis between very huge dilated proximal bowel and the distal narrow bowel. And they present with bilious vomiting, abdomen distension, and non-passage of meconium. This is the operative photograph of infantile hypertrophy pylori stenosis. You can appreciate the thick muscle mass of the pylorus producing gastric outlet obstruction. They present with non-bilious persistent projectile vomiting, and early diagnosis is required. Otherwise, electrolyte imbalance and emaciation may even kill the baby. You can look at this sick baby. You can see the nasogastric tube draining blood-stained fluid, and abdomen is getting distended, severely dehydrated, and severely ill. This baby had a malrotation bowel. You can see the barium showing hugely dilated stomach and cut-off sign of the second part of duodenum, that is suggestive of malrotation with volvulus. You can see the slide showing volvulus of the midgut. If delayed diagnosis is done, then there is no scope for life. The same baby after 2 months going into normal life. Hirschsprung's disease. You can appreciate the barium enema showing typical transition zone. And actually this baby was operated once from outside. Colostomy was done. Colostomy was closed again because biopsy was not confirmatory of the diagnosis. And they diagnosed as a case of repeated adhesion obstruction and came to me, and we did barium enema which showed a typical transition zone. So we did a single stage Duhamel operation. At that time biopsy was sent, and biopsy was confirmatory of Hirschsprung's disease. So the diagnosis, which can be easily made, can go wrong at times. The resected specimen showing the typical transition zone. That slide, because this talk is going to YouTube, I am not showing the slide. That baby had a tracheostomy in the postnatal life because of severe respiratory distress due to cystic hygroma and lymphangioma affecting the head and neck region, and still on treatment with intralesional sclerotherapy. And on neonatal infections, any part of the body can get infected and form abscess. It can affect osteomyelitis, septic arthritis of different joints, and umbilical sepsis, and peritonitis and septicemia. So abscess being aspirated, what is required is a liberal IND for the drainage of pus and appropriate antibiotics according to culture and sensitivity. On the other slide, you can see a baby who had a septic arthritis hip, underwent the septic subcutaneous arthrotomy for the septic arthritis and on traction, and this baby developed meningitis as part of septicemia. Neonatal tumors, though rare, can evolve in different ways: teratoma, neuroblastoma, soft tissue sarcomas, renal tumors, liver tumors, and brain tumors. And out of the lot, sacrococcygeal teratoma is the most common, And you can appreciate the sacrococcygeal teratoma, which is weighing more than the weight of the baby and bigger than the head of the baby. And this baby underwent total excision, and biopsy came as immature teratoma suggestive of malignancy, but now 4 years and beyond any problems. Neonatal trauma, to be avoided, to be prevented, it can involve various parts in the form of soft tissue injury, hematoma, skeletal injury in the form of fracture femur, fracture clavicle, and iatrogenic injuries like this. You can see needle in the thigh, which was removed from the neonatal ICU. You can see a baby who came with a lump over the back, which on X-ray showed a broken needle in the area, which on exploration found the needle in the retroperitoneal area. And when it became a huge issue, staff were about to be suspended. Then bystanders came forward and told that we don't have any complaint. That means the rapport between the staff and the bystanders. So any problem can be overcome if you have got very good rapport between the bystanders and the community. And and the needle I am showing because the habit of breaking the needle have injured many neonates. They all have come to us. And in one case, we had to do thoracotomy and removal of the needle because the needle got into the lungs. Baby developed a repeated pneumothorax. We did intercostal tube drainage for many times, and finally we found that a needle sitting in the lung which had to be removed by thoracotomy. So this breaking of the needle to be avoided to prevent injury to the newborns. Intussusception is a common disease between 3 months and 3 years of age, and majority occur in the below 2-year age group. And what is important is the treatment and prognosis differs according to the level of diagnosis, stage of diagnosis. If early diagnosis is made, the treatment is non-operative management in the form of saline hydrostatic reduction or pneumatic reduction. If delayed, the intussusception become irreducible, often gangrenous, may perforate, and the child may develop septicemia. So any child with vomiting, think of intussusception. Any child with persistent abdominal pain, think of intussusception. And any child passing blood and mucus per rectum, think of intussusception. So if that index of suspicion is there, there cannot be any misdiagnosis. Just showing operative reduction of intussusception. Telescoping is getting reduced. Foreign body can either be inhaled or ingested by children between the age of 6 months and 4 years. And the importance is history may not be forthcoming. Clinical signs may not be definite, but clinicians have to develop the high index of suspicion to make the diagnosis. Once the diagnosis is made with the present day amenities and instruments, equipments, foreign body retrieval is not a big issue. And the first slide, you can see a shadow in the paracardiac region on the right side, which is nothing but extracted tooth. This child had a tooth extraction, but nobody was seeing the tooth. So they ignored it. This child continued to have a cough. So continued for 3-4 months, and finally this X-ray was done, and we showed tooth impacted in the bronchus, which had to be retrieved. And on the other side, we have got open safety pin in the intestine. Everybody thought it has to be removed by surgical intervention, but luckily it came out by itself. But nature has got a big role to play. Appendicitis, I should say appendicitis is the most delayed diagnosis. It's a disease of delayed diagnosis. And the habit of empirical antibiotics further complicates the issue. And if early diagnosis, appendectomy is a simple operation, but delayed diagnosis is still complicating because you are operating on abscess, you are operating on a patient with peritonitis, you are operating on a patient in septicemia. I remember receiving a child of 10 years with appendicitis and septicemia. She was asking where I am because she was so confused in the septicemic phase. And there is high chance of future adhesions and obstruction. So appendicitis, which can be easily removed by modern day laparoscopy or open operation. And in one slide you are seeing enrobius vermicularis. So there is a role for deworming in all these children. And the other slide shows fecolith already free in the peritonic cavity being removed. And you are seeing a pool of pus in the pelvic cavity because perforated appendicitis which was neglected. In acute scrotum, there is a golden hour period, that is 8 hours. If they come after 8 hours, there is high chance of losing the testis. So the importance should be given for the 8-hour period. And clinical exam and Doppler will suggest the diagnosis. And if the diagnosis in doubt or when one is not sure, it is better to explore. And there is a female counterpart, that is torsion of the ovary, and early detorsion is required for saving gonads. You can see the gangrenous testis because delayed diagnosis and treatment. And the other slide, you can see the torsion of the undescended testis. So follow-up of undescended testis, this importance should be given, that can undergo torsion. So any child with undescended testis and coming with the pain in the local area, we should think of torsion of the undescended testis. We had a few. And the lower slide is torsion of the ovary, and you can see the twisted tube. This is the laparoscopic view. And obstructive hernia can present in different ways. On the left side, you are seeing obstructive hernia, and the content was VP shunt. And on the other side, you are seeing obstructive hernia in a female, and the herniated contents are entire uterus, both fallopian tubes, and ovaries. This is noted reported. And empyema pericardium, though rare, we come across. And empyema passes through various phases like exudative, fibrinopurulent, fibrous, and finally lung entrapment. Our aim is early control of sepsis and prevention of lung entrapment. They are not from Kerala. These children are from UP, children of circus artists, and somehow they reached Calicut. And this child with empyema thoracic was in Calicut Medical College, and newspaper reports came, and Baby Memorial Hospital took over the child. And when the child was received, he was unfit for any intervention. So we did the thoracoscopic debridement of the empyema. And on the other side, the same child, after a few months' time, he continued to be in the hospital for a while. Now he is in Kerala in one of the orphanages. And that is the child. Childhood tumors can produce emergency problem in the form of tumor rupture
Sir, 2 minutes more.
and visceral compression or vascular erosion, outlet obstruction. So you can see pericardiac tumor being removed. You can see hepatoblastoma in a child already having posterior urethral valve on vesicostomy. So pediatric trauma is a big topic. So you can see the liver injury being repaired, and the other case whether we are unable to cope up with the liver injury, there was no scope for suturing. Entire liver was pulverized. So we packed the abdominal cavity with the 2 packs, and on third day we are removing the pack. And this is the child with multiple trauma, fracture skull, liver injury, fracture femur, and lung contusion. And we are not getting into pediatric urology, which is a big topic with the posterior urethral valve, hydronephrosis, urinary tract infection, vesicular reflex. So a lot to be discussed in pediatric emergency. Thank you for the patient hearing. Thank you.
Thank you, sir. So this topic is open for discussion. Sir, one question this. Ultra short segment Hirschsprung's disease, can it present just like a functional constipation? What is the treatment? It sometimes may go unnoticed many a time.
Yes, you are absolutely right. Those children will present with constipation and not responding or resolving to medical management. So what is required is a rectal biopsy. Rectal biopsy, by doing rectal biopsy, we may be dividing the internal sphincter. That itself may be a treatment. So in my hands, almost 90% of children with ultra short segment resolved with rectal biopsy itself. So there is a good scope to wait. They may improve by itself, means by rectal biopsy itself.